Well, thank you. It's a pleasure to be here. And while I think many speakers probably tell you that, it does have special meaning for me because when I was 19 years old, I came to Bogota for 3 months and taught English. And I lived down in the old part of the city, traveled around. I had a chance to travel through other parts of the country, through the mountains, down into the grasslands. I even hitched a plane ride on a small plane into the jungle in the Vaughan region. I remember landing in Me Too to fill gas, and the Indians would take the gas plane and pass it up to a person on top of the wing, and then he would pour the gas in the wing. And then we had a rough landing in the jungle, and I remember that very well because when the pilot says, "Hang on to your seats, boys, we're going to crash," not a good sign. But the good side is that I got to spend a week living in the jungle with the Indians, and that was quite an experience. So I have many interesting memories of Colombia, and it's an honor to be here. Now, my subject, the first subject I'll be talking about is medical therapy for atrial fibrillation. And to put it in perspective, there are many consequences of having atrial fibrillation. For many patients, it can impair their quality of life. It increases risks of hospitalization. There are many expenses associated with that. It runs into billions of dollars in the United States. There's the increased risk of embolic complications and the impact that has on people's quality of lives, worsening of heart failure, and in fact, increased mortality. So as we think about how to approach atrial fibrillation with medications, the first step is to consider rate control versus rhythm control. And looking at the potential benefits and risks of rate and rhythm control. With rhythm control, of course, the rhythm is regular. Patients don't have the palpitations. Their quality of life may be improved. There are certainly some who tolerate atrial fibrillation well, but others really feel better in a normal rhythm. Almost all people have better exercise tolerance in a normal rhythm. The risk of heart failure is reduced in some patients. The problem is that antiarrhythmic drugs are potent drugs. They carry certain risks. And we don't alleviate or eliminate completely the risk of thromboembolic complications. If we're going to focus on rate control, we have to pick a target. We monitor patients at rest and during activity. An ambulatory monitor where we tell patients to get out and walk and do their usual things in life gives us a feeling of how well their rate is controlled, or you may want to have them go through a formal stress test. Typically, the target rate is 60 to 80 at rest, 90 to 115 with moderate exercise. But there really is no benefit in strict rate control as opposed to more lenient rate control, assuming there are no symptoms or heart failure associated with it. But you do have to monitor their heart function to make sure that that doesn't deteriorate. And when I say, well, what about strict versus lenient rate control? Well, there was a study that was done in which they looked at strict rate control, and most of the patients had their heart rates in the range of 70 to 80 beats per minute rest. But in the group that was lenient control, the rate at rest was in the order of about 90 to 100. So really, when this study was done, the people who were in the lenient control were pretty well controlled. It's not that they were running at 120 or 130 beats per minute. So their treatment was pretty good. But when they compared this lenient control versus strict control, there were no differences in outcomes. The endpoints they used were cardiovascular death, hospitalizations for heart failure, embolism, and bleeding and life-threatening arrhythmias. So within the context of having reasonably well-controlled rates, it doesn't have to be rigid. Is rhythm control better? Well, there have been a number of studies in which patients have been randomized to either rate control or rhythm control. And when you go through this, honestly, there isn't a clear benefit. And I'll comment on that in a moment. But looking at quality of life scores, they tend to be similar. There aren't differences in mortality or stroke. Actually, one of the stroke studies had a higher stroke rate in the patients in whom they tried to maintain a normal rhythm probably because some of their anticoagulants had been discontinued, and that was a lesson learned for everybody. But there really aren't any clear differences in heart failure in patients who have these things. But what does that mean in practice? Well, the problem is that most of these patients were 68 years old or older. So if you see a patient who's 35 or 40, it doesn't necessarily mean the same thing to leave that patient in atrial fibrillation for the next 30 or 40 years compared to somebody who's considerably older. Moreover, these were patients who didn't have any symptoms. They were selected for randomization for that reason. And most of us see patients who do have symptoms in atrial fibrillation, and they don't necessarily like it. Some of them are highly symptomatic, and others are somewhere in between. They just don't exercise as well, they feel tired, and they like to get back to a normal rhythm and feel better. So in trying to compare these studies, there have been sub-study analyses showing that the people who actually were in a normal rhythm felt better, because you see, the problem is that most of these were intention to treat analyses. And so you end up comparing atrial fibrillation to a mixture of atrial fibrillation and sinus rhythm. So I think the verdict on this is not completely in. But looking at this, this is some of the data from the FIRM trial, in which when looking at death from cardiovascular causes, you see no difference. These are secondary outcomes, death from any cause or stroke, no difference. Worsening heart failure, composite outcomes, no difference. So I think, how do we put this together? Well, I think for rate control, we may use that approach for patients who are older, sedentary, asymptomatic. They have late, persistent, or permanent atrial fibrillation where the chance of getting them back to a normal rhythm and keeping them there is relatively low. They have substantial atrial remodeling, which means they have a large atrium. They have some underlying heart disease. Perhaps they have bad valve disease, but they're not good candidates for surgery. And they have a long or indeterminate history where you can't tell exactly when in atrial fibrillation because they can't tell you, they don't know. Those patients are probably good candidates for rate control, but younger, more active, symptomatic patients benefit from sinus rhythm. And I think that if we're going to intervene, we should probably intervene on people early in the stage of their disease as opposed to waiting until there are too many changes and it's too late to do anything about it. So when we look at the guidelines, the recommendations for rate control is to control the rate using beta blockers or calcium channel blockers. You can use intravenous beta blockers or calcium channel blockers when you first need to get the rate slowed down. And in patients who experience symptoms during activity, you need to assess how well the rate is being controlled. The second level of guidelines is to work on a resting heart rate less than 80. Intravenous amiodarone can be used for rate control in critically ill patients, preferably those without pre-excitation. That's a whole other set of problems. An AV nodal ablation with permanent ventricular pacing is reasonable, but that's an irreversible decision, and so it's not something I would want to do in a younger patient if it could be avoided. Of the other options, they emphasize that lenient rate control is an effective strategy. The resting heart rate should be less than 110, excuse me. And it may be reasonable as long as the patient's not symptomatic. Oral amiodarone may be useful for rate control when other measures are unsuccessful or contraindicated. So it's not generally how I'd use amiodarone, but sometimes it's a good solution. If a patient isn't a good candidate for an AV node ablation, then amiodarone might be a way of controlling their rate. Now, there are things you don't want to do because they cause harm. AV node ablation with permanent pacing shouldn't be performed to control the rate without prior attempts to achieve good rates. The calcium channel blockers shouldn't be used in patients with decompensated heart failure. In patients with ventricular pre-excitation, you have to be careful about certain drugs such as digoxin or the calcium channel blockers because you can accelerate the ventricular response in those patients. And dronedarone should not be used to control the ventricular rate in patients with permanent atrial fibrillation because there's a study that was done showing that it led to poor outcomes. What about digoxin? It's a drug that's commonly used, it's cheap, it does work, It's not recommended as the first line of therapy. It has a delayed onset for acute rate control. During chronic therapy, it reduces resting rates, but it's ineffective or relatively ineffective during exercise. It may be combined with beta blockers or calcium channel blockers, but it has some significant adverse effects, and it requires dosage adjustments in people with chronic kidney disease. And why not dronedarone? Well, it does slow the rate down by an average of about 12 beats per minute, but it increases rates of heart failure, stroke, cardiovascular death, and unexplained hospitalizations. And in patients with heart failure and LV dysfunction, it increases the combined endpoint of stroke, for some reason MI, though that's not well understood, systemic embolization, and cardiovascular death. That's what the study showed. So what are our options in selecting drugs for rhythm management? Well, disopyramide is still in use. Quinidine, not so much anymore. We still have it in the United States, though I think I've probably written 2 prescriptions for it in the past 10 years. These are drugs that are not necessarily well tolerated. Disopyramide makes heart failure worse. Quinidine has a lot of gastrointestinal side effects. They both have some significant drug interactions. Flecainide and propafenone are commonly used. These drugs are fine in patients who are good candidates for it, and I'll go through with you how I would recommend that approach, but they can cause sinus node dysfunction, AV node dysfunction. There are some people who are slow metabolizers, and there are certain drug interactions you need to watch out for. Amiodarone is the most potent and effective medication we use. Often it seems like a good idea to start it when you start it, but a year or 2 later when people come back with toxicity, it doesn't seem like such a good idea. So we do use it certainly, but it's not the first drug I would turn to. I don't honestly know whether you have dofetilide in this country. It's a drug that markedly prolongs the QT interval. All patients who are started on it have to be admitted to the hospital. It is a very effective medication, but it has to be used with extreme caution, and it too has a number of drug interactions that could be lethal if not anticipated. We've talked about dronedarone. It can cause bradycardia. It rarely will cause liver disease. A lot of patients don't tolerate it because of gastrointestinal side effects. It has a number of drug interactions. Sotalol is another useful medication, but it's got strong beta blocker properties, and so it can cause bradycardia or AV conduction problems, and it can prolong the QT interval. It's excreted by the kidneys, as most of these drugs are, and so it can't be used with severe kidney dysfunction. So looking at the guidelines, the general approach is to start in patients, if we focus on the left, those who do not have structural heart disease, in which you'd sit down and talk to them about the benefits of being in sinus rhythm if you think they're appropriate candidates for that. There are some patients who will want to go directly to an ablation procedure, but most patients will undergo a trial of medications first. And that might include any of those listed: dofetilide, dronedarone, flecainide, propafenone, or sotalol. Personally, although we use a lot of dofetilide because of the risks and the QT prolongation, I prefer to try one of the others first, and would hold amiodarone in reserve. And generally, we would not use amiodarone in this group, but at some point earlier would have gone to a catheter ablation procedure. For those people who have structural heart disease, it's more complicated. For those who have coronary disease, it's best to stay away from flecainide and propafenone because they're pro-arrhythmic, but they may be candidates for the other drugs. They too might benefit from catheter ablation, though the success rate might be somewhat lower. And in those who have heart failure, any drug that's a negative inotrope be preferable to avoid. Amiodarone and dofetilide are the best options in those patients. So when I see patients and I'm thinking about what drug to treat them with, basically I stop and think about whether they have lone atrial fibrillation or whether they have coexisting heart disease, whether it's coronary disease or a lower ejection fraction, and what their renal function is. So if they have coronary disease, I generally stay away from flecainide or propafenone. Likewise, if they have renal failure, those drugs are excreted by the kidneys, so they're not a good option. Sotalol can be used in those categories, but not in patients with severe kidney dysfunction. Dofetilide has the same restriction. Amiodarone can be used in all these patients, but it does have its share of toxicities over the long term, and I'm sure you're all familiar with those. And then dronedarone can be used in patients with coronary disease, but what has come out is that in people who have uncompensated heart failure, they do not do well on dronedarone, and so we would avoid it in those patients. The effect of dronedarone on renal function has to be taken into consideration. It's actually not a problem, but there's a 10 or 15% increase in the serum creatinine. It's actually just the clearance of creatinine. It's not the glomerular filtration rate. Renal plasma flow is unchanged. Anion secretion is unchanged. So the rise in creatinine at that level should not be interpreted as being an impairment of renal function, but you have to be aware of it if you're starting the drug. So who needs to be admitted to start antiarrhythmic drugs? And I don't know what the practice here is in Colombia. In the United States, there are many times where I will start these drugs on an outpatient basis. Many electrophysiologists are afraid to do that for medical legal reasons. They're concerned that if anything goes wrong, they'll be sued. But I think that if we just look at it from a medical standpoint, any drug that can prolong the QT interval, if the baseline QT is borderline or prolonged, I would not start that as an outpatient. All patients who are treated with dofetilide, we are mandated to admit them to the hospital. Patients with heart failure or bad ventricular function, I would not start these drugs on an outpatient basis because I think their risk of proarrhythmic response is greater, or it might precipitate heart failure. Patients with sinus node dysfunction, sometimes it gets worse, so you'd want to watch them during that, or if they have significant AV conduction disease. So these are the kind of patients that I would always admit to the hospital. And if we look at the guidelines on drugs to maintain sinus rhythm, what the guidelines point out is first make sure there's not some reversible or treatable problem, hyperthyroidism or something else that needs to be treated before we embark on this. And then they list a number of medications that we've discussed that can be used in these patients. We have to recognize that there are risks in using these drugs, and that has to be considered before starting each drug. And owing to its potential toxicities, the recommendation is that amiodarone should only be used after consideration of other risks or when other drugs have failed or are contraindicated. A rhythm control strategy can be useful in some patients who have tachycardia-induced cardiomyopathy. We see this quite a lot, and it's very gratifying when you get the rhythm under control. Sometimes the ejection fraction will come back from 15 or 20% to a normal range. It may be reasonable to discontinue antiarrhythmic drug therapies in the setting of infrequent, to continue these drugs in the setting of infrequent recurrences. In other words, none of the treatments we have for atrial fibrillation is perfect. That's true for ablation procedures, it's true for drug therapies. And so if somebody has a rare recurrence, it doesn't necessarily mean we have to give up on that drug. We may continue to try it unless it's clear that it's not working over the long term. And the AHA does address this issue of admitting people to the hospital if they have to be, but there are certain patients where you could start these drugs on an outpatient basis. Of the things we don't want to do, the antiarrhythmic drugs for rhythm control should not be continued when atrial fibrillation becomes permanent, and this includes dronedarone. Dronedarone was used for this purpose for a while. The thought was that it would help control the rate, but it turns out that because of the toxicities of these drugs, they just aren't worth the risk as opposed to any perceived benefit. And dronedarone should not be used in people with for heart failure. So when medications fail, what do we do? And what are the recommendations for ablation of atrial fibrillation, and how does that compare to medical therapy? Well, the clearest recommendation is symptomatic paroxysmal atrial fibrillation that have been intolerant to at least one of the antiarrhythmic drugs, and that's because this has the highest cure rate and the greatest benefit. But it also can be used in symptomatic persistent atrial fibrillation under the same conditions. These are patients where the cure rates are not as high, but nonetheless the patients may very well benefit from an ablation procedure. And it can be a first-line alternative to medications in patients with paroxysmal atrial fibrillation. It should be considered in symptomatic, long-standing persistent atrial fibrillation that's been intolerant to medications, but again, the cure rates in those patients will be lower. And it may be considered prior to the initiation of an antiarrhythmic drug in patients with these symptomatic persistent atrial fibrillation. But if they've been in for a long time, often what you want to do is put them on a drug, do the ablation procedure, let the HRS recover and remodel, and then taper them off the drug later on. One mistake that sometimes people have made is patients come to us and they say, I'd like an ablation procedure so that I won't have to take anticoagulants. Well, as we'll hear in the course of the discussion today, ablation procedures offer a great deal to patients, but the recurrence rates are high. And it wouldn't be right to tell the patients that they should go through an ablation just to get off of the anticoagulants because the risks of doing that are high. They might have a stroke if the atrial fibrillation recurred. Looking at the success of ablation procedures, it depends on whether it's paroxysmal, persistent, or permanent. These are some data from a registry. I think the estimates there are reasonable. The success rates listed here for without antiarrhythmic drugs are about 75% for paroxysmal, 65% for persistent, and 63% for permanent atrial fibrillation. It may even be a little bit lower than that because we have to recognize that this is a voluntary registry and we don't know exactly how accurate that data is. You gain an additional 10% by putting people back on antiarrhythmic drugs and using what you might call a hybrid approach for the overall success rates that are listed as in the order of 72 to 83%, depending on whether the patients have long-standing atrial fibrillation as opposed to paroxysmal atrial fibrillation. And this doesn't take into account all the other factors that enter into it, whether they have mitral regurgitation, hypertrophic cardiomyopathies, or mechanical valves. All these things have an impact on the success rate of these procedures. But nonetheless, when you compare antiarrhythmic drugs to ablation procedures, generally the success rate with ablation procedures, shown in the right-hand part of the panel, is considerably greater than it is just treating them with antiarrhythmic drugs alone. So I would summarize by saying that rate control may alleviate symptoms in some patients and may be all that you have to do. But in others, rhythm control is indicated because rate control doesn't alleviate their symptoms, or perhaps they were developed heart failure, or sometimes we see that the mitral regurgitation is worse in atrial fibrillation, and that if you can get them back into a normal rhythm, they do better. The ablation of atrial fibrillation should be considered sometimes as an alternative to medical therapy, or certainly when medical therapy fails, but it does not eliminate the need for anticoagulation. Thank you.